Hi, everybody. We're waiting for a few more, and we're waiting for Dr. Pelican to come. Are you getting on? Okay, do it. And Dr. Pelican's not here yet, but as soon as he does, we'll start. Okay.
Dr. Pelican is on. Dr. Pelican, I'm going to send you a prompt to unmute. So can you hear me now?
Have we set up already?
We can hear you.
Okay, great. I'm not seeing the
Barbara, is everything okay? Is there anything you
why
need?
am I not seeing everybody? Is there?
We have some participants here, some board members, a couple members of the public.
But
Will
I'm just not
Rebecca or
seeing,
not?
I'm not seeing the participants. I'm not seeing the gallery. What do I have to do? Am I?
Oh, the black bar on the bottom, just hit participants.
Yeah,
And
I did.
the gallery will come up once I put down the
I
agenda.
see. So that's
Oh,
why.
okay.
Okay, great.
Yep.
You'll tell me when you've done it, and then I'll get started. Wilma will be on soon.
If you're ready to go, we can get going.
Okay,
Why don't we let Kevin give rules of the road?
sure.
Welcome. If this is your first time joining us virtually, you will notice that you are currently muted and everyone will remain muted throughout the meeting except for Barbara, Wilma, and Rebecca and the presenters as we move through the agenda. As we move through the agenda, the co-chairs will call on members of the public wishing to speak. You can participate by going to your reactions icon on your device and pressing the raise hand button, not the wave or thumbs up, as those will disappear. Only press it once. If you press it a second time, your hand will go back down. If you are calling on the phone, it is *9 to raise hand and *6 to unmute. Be on the lookout for a prompt asking you to confirm unmuting once the co-chairs call on you. The chat is available for technical support only to help with Zoom software problems, not to ask questions of the co-chairs. They will not see the chats. If you are using an older version of Zoom, you will need to go to the participants section where you will find the raise hand feature there. Please do not raise your actual hand or wave at the screen because we may not be able to see you. Chat me, I'm here for support. Thank you.
Thank you. I'm not sure if Wilma's on yet, and Rebecca just texted me that she will be on soon. So if you wouldn't mind, Kevin, unmuting them when they're there. I'm Barbara Rutter. I'm co-chair with Rebecca Dangor and Wilma Johnson of the Health Senior Social Services Committee of Community Board 8. And we have presented several meetings on COVID, and unfortunately, it was time to present it again. And I'm just so pleased that Dr. Pelican, who is the Chief Medical Officer at Metropolitan Hospital, has agreed to join. Just to tell you, I was at a CAB meeting at Metropolitan, and I heard what Dr. Pelican had to say, and there's just so many questions that I thought we would present it. We thank Kevin all the time for all the work that he's done, Will and Russell, our chair, and thank you so much. And Dr. Pelican, I know more people are coming, and if you'd like to get started.
And Barbara, just a quick note, Wilma is on. She called in from the phone and she's on.
Okay, great. And Rebecca will be on soon too, she said. Okay, thanks.
Good evening, and thank you for coming back the whole time.
Okay.
This is Wilma Johnson.
Oh, good evening. Thanks for having me.
Yes.
Let me see if I can share my screen. I'll run through a couple of slides. They're similar to the ones I showed at the CAB meeting, although there's a little bit of an update. So let's see if this works. Oh, there we go. That looks pretty good. So we'll do a slideshow from the beginning. So we'll talk a little bit about COVID. So, and to no surprise, if you've been listening to the news, reportable cases have been rising, both in the inpatient and outpatient silos. At Metropolitan, we've seen a few more cases admitted to the hospital. The good news is they don't stay very long, and the persons are certainly not as sick as they had been during the heart of the pandemic. The outpatient arena, as well as our own employees, have had more cases of COVID, but they too have been getting better fairly rapidly. What is new is that there are 3 new variants. This is what characterizes the COVID virus. Those spike proteins on the outside surface of the virus that are used to penetrate our good cells are constantly mutating and changing. That's what makes treating and immunizing against COVID so difficult. The 3 most recent infections are the EG.5, the F1.5.1, and the BA.2.86. These are all descendants of that Omicron virus that made up so much of the original pandemic. I pulled this slide from New York City Health and Hospitals just to give you an idea of what's been going on. This was as of last week. This graph in blue are the total number of respiratory infections that have been ongoing as we march through the month of August. So you can see that if you draw a straight line, maybe there's a slight rise. The 2 lines at the bottom are influenza and respiratory syncytial virus, and they have not yet begun to rise. It's a little early for influenza. So, as I said, the variants contain changes in the spike protein. BA.2.86 has been of some interest. It's sort of widespread throughout the globe. There's a handful of cases in Denmark, Israel, the United Kingdom, and the USA, really diverse geographic locations. And the World Health Organization is monitoring the numbers of cases of BA.2.86. So is BA.2.86 dangerous? Well, they've done some studies in Boston, Sweden, and China. Those individuals with the most robust response to BA.2.8.6 with regard to their antibodies were those individuals who were within 6 months of a recent infection. There's really mounting evidence that some of your best immunity occurs after you've had and recovered from a COVID infection. But it does suggest that the fall vaccine will provide protection against circulating COVID-19 subtypes. But you have to be careful of the study details, right? These studies on BA.2.86 were actually done on pseudoviruses. So they weren't actually using BA.2.86. What they did was take the spike proteins from BA.2.86, transplanted them onto a different virus, and then they studied those in animals, look at immune responses, and then draw their conclusions, so that it wasn't the actual virus that's used. For those of you that follow the news, you know that there is a new monovalent vaccine that is only directed against one subtype. It's directed against XBB 1.5. On Monday of this week, it was approved by the FDA. And on yesterday, the CDC's immunization panel met and concluded that it was reasonable to use this vaccine for the most appropriate populations. And we'll talk about that a little more. So we've got FDA approval and we have CDC approval for both the Pfizer and Moderna vaccines. And the hope is that this would be ready in time for the fall campaign coinciding with the influenza vaccine. The big question is, who should receive the fall booster vaccine? And I guess formally speaking, it's not a booster because it's a new vaccine against a new variant. There is general agreement among the experts that those adults over 65 and adults under age 65 with chronic conditions and immunocompromised states should receive this fall's vaccine. In addition, pregnancy, which is considered an immunocompromised state by virtue of these viruses that can attack, you know that influenza can be particularly dangerous in pregnancy. The same applies for COVID. And they feel that women who are pregnant should receive the vaccine for protection. So for this group, there is a general consensus and emphasis on general that these folks would be wise to receive the vaccine. Where is it unclear? Well, adults younger than 65 who are otherwise healthy, adolescents, and especially young children, right? So this advisory committee did meet yesterday, and as predicted, the recommendations about children are very soft, right? Many of the experts feel that it's not necessary for the children to receive the vaccine. As you step up in age, the recommendation increases, although if you are otherwise healthy and under 65, there's no absolute consensus that you must take the vaccine. But of course, you're free to do so, build immunity, and hope that if you get COVID, the goal is to have a much milder case. Who's in the probably group? Those who recently had COVID, right? So those people probably don't need this vaccine in the fall because of the studies that are mounting that show that your natural immunity, having survived a COVID infection, is probably the best protection you can have. I talked about this at the CAB meeting only because it was an interesting study. Did you ever think about in which arm you should receive your new COVID vaccine? So they did a study in Germany involving 303 patients who had already received the vaccine and then they received a booster. The variable was whether they received the booster in the same arm as the original vaccine or the opposite arm. So they split the group in half and they gave one half the booster in the same arm and the other half in the opposite arm. Then they drew blood 2 weeks after the booster vaccine, and they assayed the blood for something called killer T cells, right? T cells are a part of your white blood cell system. They are, your body produces T cells, and they voraciously go after infections in the body. These killer T cells have a particular job in trying to attack organisms like viruses. And they found that those patients who had received both vaccines in the same arm had a much higher systemic killer T cell response in the blood than those who received the vaccine in the opposite arms. Note, there's no comment here about whether those patients who received the vaccine, the booster in the same arm and had the higher killer T cell levels did any better clinically, because the study was not designed to determine how well they did fighting the actual virus. And that's what we know so far, except to say that the virus is approved, the new vaccine is approved, and Metropolitan Hospital, I know, will be gearing up to have it available for patients and our employees.
And when?
I don't have the actual date now that the approval is set. So our nursing staff is working with central office to determine the availability. And I should know something next week. So I thought that was a starting point, and I'll be happy to entertain
I have
questions.
questions.
Sure.
Kevin, do you want to help us? Is anybody asking? I don't see who's here as much.
Rita has her.
Rita has her hand up.
Great. Thanks, Rita.
It was very informative. Thank you very, very much. I have two questions. One, you said that Pfizer and other,
And Moderna.
are we waiting for that vaccine or is it already available?
It's available and ready to go. They're waiting. They were waiting for the CDC and the FDA to give the green light. So
Okay.
yes, the vaccine is available.
I never thought about which arm, I just had an arm.
Right.
However, it's also the flu time that I'm 84 and I get a flu shot every year. So if I'm getting a flu shot and I'm getting this vaccine, for sure I'm getting both. Do I put them in both the same arm? Do I put them in separate arms?
Right. So that has not been studied, right? That the study in Germany was specifically done to look at pure COVID response from your immune system. I did check the literature in preparation for this evening's talk to determine whether it would be wise to have the two vaccines on the same day or whether they should be separated. There's no medical evidence about why you should separate the vaccines by calendar. However, the calendar itself may be important, right? The timing of a vaccine is linked to when you think the virus will be most prevalent in your community or in your particular neighborhood. Before COVID, and when I was in practice as a pulmonologist, I would tell my patients, do not get the flu vaccine before October, because the usual months, the peak months for flu is December through February, March. I knew a lot of folks who would come to see me in the office and say, oh, good news, I went to CVS, I got my flu vaccine on August 31st, beat the rush for Labor Day. And I said, why did you do that? That's very early. Depending upon your immune response, your protection may wane if we have a late spike in influenza. So we know more about influenza just because we've been dealing with it for so many more years. So you can say that you really should not get your flu vaccine before mid or late October. If you know that as your fixed point, now the decision you have to make is, when do I get the COVID vaccine? If you have decided that you are in the vulnerable group. I wish I could tell you there was a correct answer. There really is not. I mean, the cases have been on the rise, but certainly there's no pandemic present here. So I don't have a good answer for you. A lot of it has to do with your individual response. If you've been getting vaccines for years and they don't bother you at all, except maybe a sore arm, then there is no physiologic reason why you can't get both vaccines on the same day.
Thank you.
Anybody else's hand?
Next is Lori Boris.
Right, Lori. Hi, Lori.
Hi, Barbara. Thank you, Dr. Percone, for the very informational discussion. And I really just have one question, which is, how is this going to be distributed? Do I go to my primary care physician? Do I go to CVS? Do I go to one of the places that the city set up all over town, last time? It's just like, how is it going to be made available?
Yeah, so my understanding is things are a little different this time in that it's not going to be that sort of governmental wide distribution of vaccine. And then most individuals are urged to go to their primary care physician to receive the vaccine if they have the vaccine. At Metropolitan, We have the good fortune of having this very large and robust ambulatory care department where our folks in our community use ambulatory care at Metropolitan as their primary care physicians. That's where we will be distributing the vaccine, in the primary care setting.
Okay, and will there be a charge for it?
So that's another good question, because this is supposed to be the first season in which the insurance companies, in which there is supposed to be a charge. I don't have those details yet about how we're handling that at Metropolitan.
Okay, so it would be wise then, I assume, to contact your insurance company if you're worried about the cost.
Absolutely correct.
Okay, thank you.
Good questions.
I
Anybody else?
don't see anyone else.
Rebecca. Hi, Rebecca. I have a few questions. First of all, I just want to again thank Dr. Pelican, and I love being on the community advisory board with Wilma for Metropolitan Hospital. And I would just urge, I've gotten my vaccines there, and it is such an easy place to get it that I would go there. You don't even think Medicare will pay for it?
Oh, it's supposed to cover it. We know, I mean, the plan is for the insurance companies to cover it. It's just a matter of having the insurance company actually billed for the vaccine, which
Yeah,
would
but
be different.
Medicare is different than, you know, if you're under 65 and you
Right.
need it. So
Correct.
most of us. So I misunderstood you. I thought you were saying we should have the flu shot and the COVID shot in the same arm. That's what I thought that was. How do you remember what arm you had? Do you remember what arm you had in it?
So I wouldn't get too caught up in this. I mean, when I was preparing for the presentation at the CAB meeting, this study just happened to have caught my eye. I mean, it was somewhat interesting.
It is.
But I think this is one of those of academic interest, right? That you might discuss over an adult beverage. I don't think that it has huge impact over what we're actually going to do for the patients.
And by the way, we're dealing with more than adult beverages at this point. We have that. Is it still considered a booster if your last booster was more than 6 months ago?
Yes,
Most
so
of us had it more than 6 months.
right. So formally speaking, a booster is supposed to boost your response
Mhm.
against the last or related to the last vaccine. This is really a different vaccine. They have made a best guess as to what the Omicron variant will be this fall, and that's how they constructed the vaccine. So it's really a different vaccine. I mean, it's still the COVID virus, but it's directed against different spike proteins. So it's a keeping up with the times vaccine.
But is it really? I'm not quite sure. It's limited in what it will protect, or do you think it would protect you against, to some degree, of all three?
So that's exactly what the Pfizer and Moderna people say, that although this is directed against one particular variant, the way they built it in the laboratory, they feel that the immune response that is generated will be protective against these most recent variants that have emerged. And they emerged after the drug companies had built this vaccine.
Okay, I was under the impression that a new one came after they did this, and it's hard to keep up with the new variants.
And you are microbiologically correct. There are new ones, but they're hoping that they have enough similarity
Right.
that they will be zapped by your immune response.
And you have no worry at this point. Those who are of age, we've had a couple of pneumonia shots. We've had a couple of shingle shots. We get had several COVID shots. We get the flu shot every year. And then I'm going to ask you about one other. You don't worry at all about being over-vaccinated at all?
I don't, in part because as a pulmonary critical care physician over the years, I've seen too many people ravaged by the actual disease. So when I weigh risk versus benefit, In general, I see huge benefit from these vaccines as evidenced by the influenza experience compared to the risk of over vaccinating.
And we're not building it up where it's like, it's not like having too many x-rays where, you know.
It is not. And
Okay.
if we remember back what we do to it, what do we do to the young babies after they're born, right? And they go back to the pediatrician. They just seem to get vaccine after vaccine
That's
after
right.
vaccine, and they do fine. And we're trying to protect them against serious illness.
Somebody had said that they call that being healthy. What is that other?
Police has her hand up.
Oh, I'm sorry. Okay. Thanks for interrupting. Do that, Rebecca. Who is it?
It's Felice.
Hi,
Barbara.
Felice.
Hi. So thanks so much. This was a really interesting presentation this evening. I just have one question. I wasn't clear. Will you still be able to go to CVS, Walgreens, you know, the city MDs if you want to be able to get the vaccine, or do you have to go to your primary care physician?
So my understanding is that it will be available, but they'll be, and of course they'll be submitting a bill to your insurance company for the reimbursement. But that is my understanding, and that's the spirit of the clearance by FDA and CDC, is to have it available at those venues as well.
And do you know when they'll be available?
So the pharmaceutical companies are ready to go. Now it's a matter of getting them packaged and shipped out, right? So that usually takes a little bit of time. But I don't know. That's why I don't even know at Metropolitan when we'll be ready. We should know something next week. That information comes from New York City Health and Hospitals Central Office.
Thank you very much. I appreciate the information.
Sure.
I have a question. Hello?
Yeah. Hi, Wilma.
Yes. RSV.
My
It
next
is
question.
recommended for people that are over 60 that have a compromised immune system to get the shot. What is the difference between that shot and the regular COVID shot? And there's 3 shots to have now.
You
With
are correct.
RSV, the COVID shot. What's the difference between those shots?
Yeah.
The RSV and can you just take the RSV and not take one of the other ones?
So your observation's correct. When it rains, it pours, right? Sometimes it's too many choices, too many vaccines. But the development of the vaccine against this respiratory syncytial virus is new. They're very excited about having the ability to give a vaccine now. So this is a completely different virus. I mean, that's what the RSV is. It's respiratory syncytial virus. It's best known for its involvement in young children, but it can certainly attack adults as well. We didn't always test for it when an adult had an upper respiratory infection. I mean, if you had a cold and you were coughing and you might have been wheezing, you could have had respiratory syncytial virus. And as an adult, we did not always test for it because with supportive care, you'd get better. There isn't very much to do. What's new is that there's now a vaccine available to prevent either getting it or getting a severe case. And you're right.
So
now you're looking at influenza, COVID, and RSV.
And the flu.
Yeah, that's influenza.
Right, that's influenza. That's the flu. Right. So COVID, flu, RSV. Right.
Right. We need a third arm.
3 shots.
Correct.
Yeah. Okay. Well,
any others?
I just found out about the RSV, so that's what I was concerned about. Is it necessary to take them all? I guess I can find out. But I'm tired of getting stuck.
I can't argue with you. You're correct.
Right.
Good.
Can I ask, Rebecca, can I ask?
Go ahead.
Okay.
Yeah.
What I found very interesting is how they're discovering people that have COVID because we don't go and get tested anymore. It's the wastewater. Is that what's happening, or do you just know from people coming to the hospital, you know, more anecdotally rather than
So the testing of the wastewater is used for the epidemiologic studies. That is to say, is the incidence of the virus rising in the community and in the population? So that's how they're using the wastewater as a vehicle to measure the viral particles, as opposed to having to test every individual and determine what the rate is. For any given single person who has symptoms, you still require a nasal swab to test, either by that PCR method or by the home antigen tests.
I'm finding most people are not doing it. They say it's just a cold and you have to hope that's okay. Are you wearing a mask on the subway or anything like that?
I am not. The only time I wear a mask is when I go to see patients on the inpatient service at the hospital, because that is the recommendation from our central office.
I have a friend, I don't think she's on. She wasn't sure if she could make it, but I'm asking a question. She's going on a big trip to Europe that includes a cruise, and she wanted to make sure she got all her shots 2 weeks before. I don't think she's going to make it. She's leaving somewhere in the beginning, end of September or beginning of October. Do you think that 2 weeks, she was told that you should get it 2 weeks before to make sure that it bumps in. Is that true?
It is. I mean, your immunity doesn't appear instantly. It does take a little time. That's why the recommendation for influenza vaccine was for October, so that by the time you hit the mid-November Thanksgiving era, time on the calendar, your immunity has risen and you're well protected for the onslaught in late November, December, January. So 2 weeks is a good measure. Yes, I agree.
But she won't be able to do it. It probably won't be available in the next week or so, right?
Well, it depends upon how fast they move with this distribution.
Okay.
Now that it's been approved,
I'll tell her
we'll
to
have
do
see.
it.
Yes.
Let me just see. I think those are. I think that's most of my questions. So just to recap, you're saying that we should get the flu shot sometime in October. You think we should get the COVID shot as quickly as possible for those of us that are of age? And
given what has been changing recently, yes.
I just had an argument with my daughter when she said she wasn't going to get it. I said, yeah, now I can tell her she doesn't have to get it. She's not the age.
So let me leave you with this thought. One of the things we teach the medical students is something called shared decision-making, in which the patient and your provider have to come together to discuss a plan of care.
Right.
This is very much a shared decision-making situation here. And the question on the table that the patient and the doctor must consider is, do you consider me a part of the, quote, most vulnerable population when it comes to the COVID vaccine? That's the question on the table. It is not a question that has an absolute yes or no. It's a risk versus benefit decision. And it really does have to apply to each individual. That's why I like the idea of, at the very least, discussing it with your provider, even if you don't get the vaccine from your physician and you get it from CVS. I'd like to hear that you had a shared decision-making discussion with your physician.
What are the risks? And there are those people that are going to be allergic to it, but they should know that already. Am I right? What are the other risks? Like, what is the risk of me taking it?
So as a general rule, given what we know about these COVID messenger RNA viruses, the risks are very low. Ironically, the risks were highest in the adolescent group, and those young adults that got myocarditis, inflammation of the heart. The risks in the adult group were, no more than any other risk from any other vaccine, ranging from a sore arm to a bizarre reaction, dropping your blood pressure, feeling lightheaded, that sort of thing. But
which is a temporary thing, right? Some people just felt crummy for a day or two. consider that a.
That's right, right. And that's from, actually, I think that's a good sign when you feel crummy. To me, that means your immune system is doing what it's supposed to do. It's
Working.
gearing up, right, in response to the vaccine.
And that's another question I had. So several months ago, maybe 6 months ago, I had my checkup with my internist, and I said, should I get another booster? It was 6 months at that point, and the old booster. He took my blood and said, we'll test you for the antibodies, and said I had very high antibodies. He was somehow able to tell what came, because I only had a very mild case of COVID once, and what I had from the immunizations. Do you agree with that?
So the antibody measurement is available. It is not currently a widespread recommendation that everybody make their decision based on an antibody level. And some of that is an economic decision, right? I mean, that would drive up the cost of healthcare very significantly if everybody was having an antibody level measurement to make the decision about the vaccine. Plus, the antibody is not, as I understand it, specific against a particular variant. If you have an antibody level, you're not sure exactly what it's directed against, other than you have antibodies in the blood. But what is important is that if those antibodies are there because you recently had COVID or recently had a vaccine, the population studies show that you're going to do well and that you're probably protected. So there's another shared decision making, right? The fact that you have the antibodies would speak in favor of not getting this new vaccine. On the other hand, age might point you in the direction of taking it, especially if there are no side effects.
He was talking about the old one where my antibodies would have been protected by the old.
That's correct. That's correct.
But not the new one. And one other thing, when I did have a very light case, it turned out a light case of COVID, I did call him to tell him I was positive, and he did not want me to take Paxil. Is that what it's called? Paxil. He said that it doesn't help you with the antibodies, and people do get sick again. I know President Biden and his wife, they got sick a second time after taking it. Do you agree with that?
Yeah, I do. I haven't been impressed by the results from Paxlovid. That's correct. Yes.
And he said people don't get the antibodies that you want from.
That's right. We don't do those immunoglobulin infusions as we were doing during the height of the pandemic when that variant was particularly virulent. We are fortunately not seeing that degree of virulence with the current strains.
And will there ever be a time when we don't have to ask you to come back to talk about COVID? Well, we love seeing you.
I guess after I retire. But I mean, epidemiologically, probably not. This is probably going to be like influenza. It's probably going to come up every fall with a different subvariant. And the decision will have to be made as to whether it is important enough to develop a vaccine against COVID, as we've done for influenza.
Do you ask your hospital to get the influenza vaccines? Do they have to be vaccinated?
Oh, absolutely. Yes. You either have to, if you're as an employee, you either must have the flu vaccine or you must sign a declination, and then you're doomed to wear a mask for the whole winter season.
Okay, that's good. Any other questions? No? I want to thank you so much. It was last minute that I asked Dr. Pelican.
Appreciate all the information. It's really very thorough.
Right.
And I learned a lot.
I'm going to ask one other thing. Should we be pushing people to come to Metropolitan? Is it good for Metropolitan if we get our?
There's a primary care at places. They have a primary care doctor. They should be pushed to come. Otherwise, it's going to be very hard for them to get that whatever they need without having to be sign up in that primary care clinic. Is that right, Dr. Pelican?
Well, yes, it is preferable that you have us as your primary care provider, right? And we have room. We have plenty of room. We've just brought on several new internists. So we've got room to absorb new patients as primary care providers. So we'd be
Good.
happy to have you join.
I think I'm down as you being my primary care. I want to thank you if there's nobody else.
Thank you.
Okay, thanks very much for
Thank
the
you.
opportunity. Have a
See
good
you
night
Good night.
Next
All
month.
right.
Thank you so much.
and stay safe.
Okay, good. Bye-bye.
You too.
Thank you.
Bye.